Good morning, students. In this class, we will see about the high-risk approach with screening and assessment. The definition of high risk is all pregnancies and deliveries are potentially at risk. However, there are certain categories of pregnancies where the mother, the fetus, or the neonate is in the state of increased jeopardy. About 20 to 30% of pregnancies belong to this category. The pregnancy and childbirth global situations in 180 to 200 million pregnancies every year, 25 million unwanted pregnancies, 50 million induced abortions, 20 million unsafe abortions, 20 million women suffer from maternal morbidity, 60,000 die from complications, 3 million newborns die within the first week of life, 3 million babies are born dead. In every minute, 80 women become pregnant. Among 190 women face unplanned or unwanted pregnancies. 110 women experience pregnancy-related complications. 40 women have unsafe abortion. 5 babies are born dead and 5 newborn die. And 1 woman dies. Though all mothers and children are vulnerable to disease or disability, there are certain mothers and infants who are at increased or special risk of complications of pregnancy or labor or both. If we desire to improve the obstetric result, this group must be identified and given extra care. The factor is defined as any uncertainable characteristic or circumstances of a person or a group of persons known to be associated with the abnormal risk of developing or being adversely affected by the morbid process. That is the meaning of high risk. A high risk pregnancy is defined as one in which complicated by the factor or factors that adversely affects the pregnancy outcome, that is maternal or perinatal or both. Introduction to assessment, screening, and risk approach. The first one is assessment. Assessment is the process of defining the nature of that problem, determining a diagnosis, and developing a specific treatment recommendation. Second is screening. Screening is a process of identifying apparently healthy people who may at increased risk of disease or condition. They can be offered information, further test and appropriate treatment to reduce the risk and or any complications arising from disease or condition. Screening of high risk. The cases are assessed at the initial antenatal examination, preferably in the first trimester of pregnancy. This examination may be performed in a big institution, big means teaching or non-teaching, or in a peripheral health center. Some risk factors may later appear and are detected at the subsequent visit. The cases are also be reassessed near term and again in labor for any new risk factors. Risk approach according to WHO. The main objective of the risk approach is the optimal use of existing resources for the benefit of majority. It attempts to ensure a minimum of care for all while providing guidelines for diversion of limited resources to those who most need them. Inherent in this approach, the maximum utilization of all resources, including some human resources that are not conventionally involved, such as traditional birth attendants, women's group. The high risk according to WHO during pregnancy, elderly primary gravida above 30 years of age, short statured primary that is less than 140 cm, threatened abortion and antepartum hemorrhage, malpresentations and malpositions, preeclampsia and eclampsia, anemia, elderly grand multiparas, twins and hydramnios, previous stillbirth, intrauterine death, manual removal of placenta, prolonged pregnancy, history of previous cesarean section and instrumental delivery, pregnancy associated with medical disease. During labor, premature rupture of membrane, prolonged labor, hand, feet or cord prolapse, placenta retained more than half an hour, PPH, puerperal fever and sepsis. The cause of present pregnancy, the case should be reassessed at each antenatal visit to detect any abnormality that might have been arisen later. Examples are preeclampsia, anemia, Rh isoimmunization, high fever, pyelonephritis, hemorrhage, diabetes mellitus, large uterus, lack of uterine growth, post-maturity, abnormal presentation, twins, and history of exposure to drugs or radiation, acute surgical problems like appendicitis. Complications of labor. It include anemia, preeclampsia, eclampsia, premature rupture of membrane, amnionitis, abnormal presentation and position, disproportion floating head in labor, multiple pregnancy, premature labor, abnormal fetal heart rate, clients admitted with prolonged labor, obstetrical labor, rupture of uterus, clients having induction or acceleration of labor. Certain complications may arise during the labor and place the mother or baby at high risk. They include intrapartum fetal distress, difficult forceps or breech delivery, prolonged interval from diagnosis of fetal distress to delivery, postpartum hemorrhage or retained placenta, and postpartum complication. PPH, retained placenta, shock, inversion, sepsis may develop later on. These are the uneventful labor may suddenly turn into an abnormal one in the form of PPH. And newborn, UPGA score below 7, birth weight is less than 2500 gram or convulsions, respiratory distress syndrome, hypoglycemia, fetal infections, persistent cyanosis, anemia, major congenital anomalies, and jaundice. Birth weight less than 2500 gram or more than 4 kg. The screening and assessment. Initial screening include maternal age, reproductive history, preeclampsia, anemia, third stage abnormality, previous infant with RH, isoimmunization or ABO incompatibility, medical or surgical disorders, psychiatric illness, cardiac disease, viral hepatitis, previous operations, myomectomy, repair of complete perineal tear, repair of vesico-vaginal fistula. The family history includes socioeconomic status, family history of diabetes, hypertension, multiple pregnancy in the maternal side, and congenital malformation. Diagnostic test. This test is to establish presence or absence of disease for the treatment decisions in the symptomatic or screen positive individuals. Diagnostic tests for high-risk pregnancy include non-invasive diagnostic are fetal ultrasound or ultrasonic testing, cardiotocography, non-stress test, contraction stress test. Invasive diagnostic tests are include chorionic villus sampling, amniocentesis, embryoscopy, fetoscopy, and percutaneous umbilical cord blood sampling. The non-invasive diagnostic are fetal ultrasound. Fetal ultrasound is a test done during pregnancy that uses reflected sound waves to produce a picture of a fetus camera, that is in a GIF, the organ that nourishes the fetus, that is the placenta, and the liquid that surrounds the fetus, that is the amniotic fluid. The picture displayed on the TV screen may be black and white or in color. The pictures are also called sonogram, echogram, or a scan, and they may be served as a part of baby's record. Fetal ultrasound camera is done to learn about the health of the fetus. Different information is gained at the different times during pregnancy. This exam typically done between weeks of 18 to 20 of week of pregnancy. However, the timing of ultrasound might be altered for reasons as obesity or prior surgical incision and scanning site, which could be limit visualization of the fetus. Most women get an ultrasound in the second trimester between 16 to 20 weeks of pregnancy. Some also get first trimester ultrasound, also called early ultrasound, before 14th week of pregnancy. The first trimester ultrasound is done to determine how pregnancy is progressing, find out if the female pregnant with more than one fetus, estimate the age of the fetus, estimate the risk of chromosomal defects as Down syndrome, check for certain birth defect, that is brain or spinal cord. Second trimester, estimate the age of the fetus, look at the size, position of the fetus, placenta and amniotic fluid, determine the position of the fetus, umbilical cord, placenta during the procedures, thus amniocentesis, detect major birth defects as neural tube defect or heart problems. Third trimester, make sure the fetus is alive and moving, look at the size, position of the fetus, placenta and amniotic fluid. Second, non-invasive is cardiotocography, otherwise known as CTG. This is a technical means of recording, that means graphy, fetal heartbeat, that is cardio, and uterine contraction, that is toco. During pregnancy, typically in the third trimester, the machine used to perform monitoring is called cardiotocography, more commonly known as electronic fetal monitoring. Interpretation of a CTG requiring both qualitative and quantitative description of uterine activity, baseline fetal heart rate and baseline fetal variability. This is a picture of a fetal heart, means CTG, which shows the baseline heart rate is 140. Non-stress test. A non-stress test is a common prenatal test used to check the baby's health. During non-stress test, also known as fetal heart rate monitoring, a baby's heart rate is monitored to see how it is respond to the baby's movement. Typically, a non-stress test is recommended for a woman in increased risk of fetal death. A non-stress test is usually done after the 26th week of pregnancy. Certain non-stress test results might indicate that client and baby need further monitoring, testing, or special care. This is an example of a picture of a non-stress test, acceleration of 15 beats per minute lasting 15 seconds with each fetal movement. Contraction stress test. It is performed near end of the pregnancy to determine how well the fetus will cope with the contractions of childbirth. The aim is to induce contractions and monitor the fetus to check for heart rate abnormalities using cardiotocography. Contraction test, rarely used nowadays, measures the response of fetal heart rate to contractions. The test requires 3 contractions in 10 minutes. Positive or abnormal test result, the deceleration is in more than half of the contractions. Negative result, no deceleration with contraction. Contraindication, any case of where labor is not allowed. Other prenatal examinations include chorionic villus sampling, amniocentesis, chordosynthesis. These are the invasive diagnostic tests. The first one is chorionic villus sampling. Chorionic villi are the small structures in the placenta that act like a blood vessels. These structures contain cells in developing fetus. A test that removes a sample of these cells through the needle is called chorionic villus sampling. CVS is a form of prenatal diagnosis to determine chromosomal or genetic disorders in the fetus. It takes place nearly 10 to 12 weeks of gestation, earlier than amniocentesis or percutaneous umbilical blood sampling. Second is amniocentesis. It is a test that done during the pregnancy to look for birth defect and genetic problems in developing baby. Amniocentesis removes a small amount of amniotic fluid from the sac around the baby. It is most done in the doctor's office or a medical center, need not to stay in the hospital. This includes women who will be 35 or older than they have a screening test which result that shows there may be a birth defect or other problem, had other babies with birth defects, have a family history of genetic disorders, may choose genetic counseling before this procedure. This is allowed to learn about other prenatal tests, make informed decisions regarding options for prenatal diagnosis. This is how we collect the amniotic fluid for amniocentesis. So it is a diagnostic test, 99% accurate for a diagnosing Down syndrome. It is usually done between 14 to 20 weeks. Amniocentesis can be used to diagnose many different gene and chromosome, including anencephaly, Down syndrome, rare metabolic disorders that pass down to the families, other genetic abnormalities like trisomy 18. Percutaneous umbilical cord blood sampling or chordosynthesis. Chordosynthesis is also known as percutaneous umbilical blood sampling. Is a diagnostic test to examine blood from the fetus to detect fetal abnormalities. Advanced image ultrasound determines the location where the umbilical cord insert into the placenta. The ultrasound guides a thin needle to the abdomen, uterine walls to umbilical cord. The sample is sent to the laboratory for analysis and result usually available within 72 hours. Procedure is similar to amniocentesis except objective is to retrieve blood from the fetus. Chordosynthesis is usually done when diagnostic information cannot be obtained through amniocentesis, chorionic villus sampling, ultrasound, or results of these tests are inconclusive. Chordosynthesis may be performed to help diagnose any of these following like fetal malformations, fetal infections like toxoplasmosis, fetal placental count, fetal anemia, Rh isoimmunization. So then we can go to the management of high risk. The high risk cases should be identified and given proper antenatal, neonatal, neonatal care. This is not to say that healthy, uncomplicated cases should not get proper attention, but in general, they need not be admitted to specialized centers, but the care can be left to properly trained midwives and medical officers in the health centers or general practitioners. It is necessary that all expectant mothers are covered by the obstetric service of a particular area. The service of a trained community health workers and assistant nurse cum midwife of the health center should be utilized to provide a primary care and screening in rural areas. Cases with significantly higher risk should be referred to a specialized referral center. Cases from a rural area may be kept as maternity waiting homes close to the referral centers. Cases having previous unsuccessful pregnancy should be seen and investigated before another conception occurs. Complete investigation for hypertension, diabetes, kidney disease or thyroid disorders should be undertaken and proper treatment instituted to a non-pregnant state. Sexually transmitted disease should be treated before embarking on another pregnancy. Cervical tears should be repaired in the non-pregnant state. Serology for toxoplasma, IgG, IgM, and antiphospholipid antibodies should be done and corrected appropriately when found positive. Folic acid 4 mg per day therapy should be started in the pre-pregnant state and continued throughout the pregnancy. Early in pregnancy, after the initial clinical examination, routine and special laboratory investigation should be undertaken. Men with history of previous first trimester abortion should be advised to rest and to refrain from sexual intercourse. Vaginal examination should be avoided in the first trimester in these cases. Clients suspected to have cervical incompetence should have sonographic evaluation early in second trimester so that cervical circulage, if necessary, may be performed at appropriate time. Clients having premature labor, unexplained stillbirth, intrauterine growth restriction, and any other abnormalities benefited by prolonged rest in the hospital with close supervision. Organization aspect of management: strengthen the midwifery skills, community participation and referral system, proper training of resident, nursing personnel and community health workers, arranging periodic seminars, refresher courses with participation of workers involved in the care of these cases. Concentration of cases in specialized centers for management, community participation, proper utilization of healthcare manpower and financial resources where it is most needed. Availability of prenatal laboratory for necessary investigations, availability of good pediatric service for neonates. Lastly, improvement of economic status, literacy and health awareness of the community. Thank you. Thank you for listening.